Hello, good morning. Welcome to our webinar about the medical aspects of the surrogacy and egg donation process. We are here today with Dr. Mottla from Shady Grove. Thank you so much for participating, Dr. Mottla. We're so happy to have you. A little bit about Dr. Mottla. Dr. Mottla is a recognized top reproductive endocrinologist with Shady Grove Fertility, one of the largest, if not the largest, fertility clinic in the United States with locations across Maryland, Pennsylvania, Virginia, Georgia, Florida, New York, Washington, D.C., as well as a state-of-the-art laboratory, surgery center, and office in Santiago, Chile. Dr. Mottla received his medical degree from Boston University School of Medicine, where he won the Dr. David Rothbaum Award for Superior Academic Achievement in Obstetrics and Gynecology and Compassion and Understanding towards patients. He has also been honored for his integral role in helping to pass the Maryland Fertility Preservation Bill. Dr. Mottla has also been recognized by Washingtonian Magazine and WhatsApp Annapolis Magazine in the Top Doctors edition for reproductive endocrinology and infertility. Dr. Mottla sees and consults with patients who need care in all areas of both infertility and reproductive endocrinology. His area of interest is in the evaluation and care of couples utilizing gestational surrogacy and egg donation, and that is what we're here to talk about today. Thank you so much for participating.
Thank you, Perla. That's a very generous and kind introduction.
Shady Grove,
Shady Grove Fertility is the largest practice in the country, but I always want to underscore we're as small as one doctor, one nurse to one couple or one patient. We have the value of having colleagues back and forth up and down the East Coast, but we're as small as, again, one doctor and one nurse to one patient. So with that background—
I can attest to that. Having worked with Dr. Mottla for so many years, he's always given that personalized care. He's just one phone call away and always available for the intended parents. So it is really a pleasure to continue working with you, Dr. Mottla.
Well, Perla, that's mutual. Let's add to what our participants want to know this morning, and hopefully we'll answer some questions as well.
Of course. So I am going to share my screen here. Dr. Mottla has a presentation in PowerPoint. And here we go. Just let me know when you want me to go to the next slide.
Okay. So many of you know something about surrogacy, something about egg donation, something about IVF, but we wanted to try to add to that today. It's a complicated entity if you're not involved in it. It's hard to know sort of how the pieces fit together. I think I'd begin by saying, whoever you choose for a doctor or a clinic, they're your source to coordinate everything you need, be it eggs from you, be it eggs from an egg donor, and be it your surrogate. So a good clinic, a good doctor does it all for you. Next slide. So who are surrogates or gestational carriers? They're very special women who enjoy being pregnant and have been pregnant successfully. And we're very stringent about their medical history, their social history, and their obstetrical history. Essentially, we want someone who's has a great medical history and has delivered one or more babies seamlessly without complications. For everybody who uses a surrogate, this has been a long road for most people, and you want the best outcome that we possibly can predispose for you. So screening is very important. Next slide. Again, we're looking for the healthiest person with the best background we possibly can, of certain age, without issues of diabetes or blood pressure or other things. Aside from their health, we want them— Perla, can we back up? Yeah. Aside from their health, we want them to have the most normal anatomy that we can find. And in the first slide, you're looking at an ultrasound of the uterus. The uterus is pear and shaped. You're looking at a black area in the middle of that pear shape, and that's fluid. This is a saline sonogram proving the uterine cavity is normal, without entities like polyps or scar tissue, and is part of preparing a surrogate for a transfer we do this as a practice transfer, proving we can pass a small soft catheter into the middle of the uterus and recreate what the fallopian tube does, bring an embryo down in the middle. The panel on the right side is an excellent uterine lining. You see the two cursors and you see a bit of a third line in the middle. This is an excellent developed endometrium or lining. And in surrogacy transfers, what we do is we coordinate or synchronize, better said, the embryo with the lining. And the last panel below on the right is a baseline exam as well. So the saline sonogram proving normal, the endometrial check proving a nice thick lining. These are the components we need for a great outcome. Next slide. People always, this is an X-ray called a hysterosalpingogram, a large tongue twisty term. We say HSG, and you should too. And people always ask, why do you need an HSG looking at the woman's fallopian tubes when we're not using her tubes? The simple answer is that if there's fluid in the fallopian tubes or some disease condition, that fluid can go back in the uterus unbeknownst to everybody and stop the pregnancy. So for a surrogate, we want either open tubes, potentially blocked tubes, as if a woman has had a tubal ligation sterilization, that's fine too, but we don't want fluid in the tubes. That breeds lack of success. Next slide. So this is all about coordinating the lining called the endometrium with the embryo. And we typically do that, we typically do that in a number of different ways. There are many protocols. They all begin with estrogen, either in a pill form, an injectable form, or a patch form. The first part of this is putting the ovaries to rest with the surrogate using a birth control pill. And essentially what we're doing is isolating the uterus and giving the uterus the estrogen it needs to develop a lining. Once we develop a thick lining, like we saw on the other slide, then we change that lining to a pregnancy lining with progesterone and essentially match the embryo with the lining. This picture here is a picture of what's called the blastocyst embryo. This is a day 5 of life embryo, and this is what we're matching with that lining. Next slide. So as technology has improved, especially freezing process, freezing now is successful as fresh. There's no difference in doing so. And what's made the difference is we've now gone to a flash freeze process called vitrification. The freezing is so fast that it happens before ice forms. Typically, ice forms with anything water, as we know, and ice can damage tissue. Ice crystals can damage tissue. Vitrification is so fast, this doesn't happen. So this leveled the playing field in terms of fresh embryos or frozen embryos. That gives us wonderful convenience and care when we're dealing with surrogacy. Essentially, what most cases of surrogacy now start with is creating embryos, either from the eggs of the patient or the eggs of the donor, fertilizing those eggs with partner sperm or donor sperm, and creating embryos and freezing them at this stage called the blastocyst. Once that happens, you actually know what you have for embryos, and hopefully you have a couple. That allows us to coordinate a transfer easily, conveniently for your surrogate. Again, especially with travel issues and COVID issues and so on, the coordination is just seamless. The couple or the surrogate actually pick the day of the transfer a month or two ahead of time, and we build back a treatment plan on a calendar for them. Remarkably convenient. Next slide. So to understand how we do this, you really need to understand a little bit of the IVF process itself. Back up one, Perla. Okay. So on the right side, you see hormonal stimulation of the ovary. We use natural hormones that are injected twice daily over roughly 10 days to develop, hopefully, average of 12 eggs. The eggs are retrieved by a minor surgery called egg retrieval. It's done as a vaginal procedure. It's done in about 15 minutes, and it's done with a small needle, and there's no intubation. Person is breathing on their own. It's a safe process for someone who's slender and healthy. Once we have the eggs, then we get the eggs together with sperm, either putting them together or injecting them, or injecting one sperm in the egg. That injection is called ICSI, and pronounced ICSI, and it stands for intracytoplasm, meaning the interior of the egg, sperm injection. Once we grow that embryo, then we transfer that embryo back here, as you see on the right panel. Again, typically now what we do is we don't do the transfer piece, we freeze the embryo at that blastocyst stage we just talked about. Next slide. So to make this possible, some amazing technology and engineering has enabled this. You're looking at, back up, yeah, you're looking at our laboratory, and you're looking at one of our skilled embryologists working at a table. That table is an anti-vibration table, because in every building that in every building, there is a movement of the building that we can't feel in the macroscopic world, but in the microscopic world, that microscope is bouncing back and forth. So this is a very expensive anti-vibration table that dampens that down. On the microscope stage, there are two arms. One holds the egg of the embryo, and the other injects the sperm or does the biopsy. The controls move these two arms a millionth of an inch at a time, and it's an amazing skill set for the folks who do this. On the left-hand panel, you can see those two arms in the dish, and there are microscopic needles that do the manipulation. And it's really sort of a fascinating thing to hold one of those needles. We actually see the needle, and then the needle blurs as it goes from our macroscopic eye capability into the microscopic. So the blur is not our eye, but the fact that we can't see the microscopic part of the needle. It's kind of a mind bender of sorts. Next slide. So now we're looking at some embryos. On the left-hand panel, you see a human egg. The next panel is an early embryo. On day 2, the embryo becomes multiple cells. On day 3, it's roughly 8 cells. And at day 4 to 5, it evolves into a blastocyst. A blastocyst, by definition, has fetal cells in one corner, here about 9 o'clock. The cells around the edge make up the placental tissues. And this is a very likely embryo to become a baby. How likely? Somewhere around 50 to 60%. That may not sound as desirable as it really is, but remember, our human pregnancy rate is somewhere between 20 and 25% at the best optimal age that we can ask for. So in IVF, we've doubled nature easily, or tripled nature. That doesn't happen very often if you think of things like life expectancy or other things. And we're striving to do even more for raising success rates and screening embryos. Next slide. So one of the ways we screen embryos is something called PreImplantation genetic testing, or PGT. And it actually is PGT-A. A stands for a condition called aneuploidy, too many chromosomes or too few chromosomes. We all have 46, women XX, men XY. Abnormal embryos tend to have 47, 49, 35, etc. And these are embryos that can't become a pregnancy. But the point is, as we look at an embryo, we can't tell the genetics. It's like looking at your favorite automobile in the parking lot. It may not have an engine, even though it looks good to us. So we have a way of testing embryos now. Next slide. So what we're able to do is, when this turn, we're able to take cells, back up, yeah. We're able to take cells of the placental tissue, here called the trophoblast by that arrow, 4 or 5 cells, and ask the question, is this embryo normal? And if it's normal, our confidence that it will become a pregnancy is higher. There is some error in the test. It's not a perfect test, but it's the best we have at this point. and we're using it selectively in patients we feel it benefits the most. Those patients are couples who've had miscarriage, couples who are in their later 30s, or anybody else with medical history. We are using it, some practices use it very, very commonly, and it's a conversation that we always have with our patients about the risks, the benefits, and the alternatives. Next slide. So again, we sort of want to end here where we started. We want to promote a healthy, normal, single pregnancy, in that anything other than a single pregnancy in a human has risks of miscarriage, twin complications, things that we just don't want. We want simple, safe, for this amazing person who's your surrogate. Perla, are there any questions at this point that we can discuss?
Yes, thank you so much for that comprehensive presentation, Dr. Mottla. I am curious to hear, or I would like you to share, please, with our viewers, what are you looking for in a woman that wants to become an egg donor and wants to help intended parents that need that help? And what are you looking for in a surrogate?
Okay, similar answer. We're looking for safe, healthy, committed, with great medical histories. For an egg donor specifically, we're looking for a woman of robust fertility. We're looking for a woman probably 30 or under, because age contributes to abnormal eggs. So the younger the person, the better. The best egg donors are probably between 21 and 30, with robust fertility and a great health history. And we recognize that our patients will be very discerning in who they choose as an egg donor, for health history. In other words, we can't change what's in ourselves. We accept what's in our partners or spouses, but as you look objectively at a profile, you're looking and you're being very particular, as you should be. So great health history. We don't want to have any histories of mental health issues, bad diabetes or heart disease in the family, or really anything else. And that process is stringent. In other words, most women who apply to be egg donors are not accepted. There's probably a 95% disqualification rate. It starts with a screening questionnaire, which is very broad. It then goes to a medical exam, a psychological exam, a fertility assessment, and typically a face-to-face with a health practitioner. And only after all those hurdles have been met is somebody qualified to be an egg donor. Similar in surrogacy, we're looking for that healthy person who's had a great obstetrical history, who's delivered babies easily.
Thank you for that. I did have a question that I feel that so many people are curious about, back to the creation of the embryos.
Sure.
Can you share the difference and the overall success realistically with creating embryos with a frozen egg versus a fresh egg?
Sure. That's a great question. Let me just touch on one aspect of screening that I didn't. Should mention that our FDA regulates egg donation, and they regulate it at the level of organ donation, which is very stringent and very comprehensive. So the egg donor goes through multiple blood tests and exams that are forwarded to a government lab for validation. So have full confidence this egg donor has been screened, scrutinized in a serial way. So there's really, I would tell you, there's just, I can't imagine any chance of anything infectious being passed to anybody in the screening and scrutiny that that donor has to go through.
Yeah, that's helpful for sure.
So your question was about frozen eggs versus fresh eggs.
Correct.
So back to the method called vitrification that really changed everything. Embryos are big and full of fluid, and we freeze them by dehydrating them. Sperm are small cells, and they freeze really well. Eggs were always hard because they're big cells full of cytoplasm, and they were prone to tissue damage by freezing. So it wasn't until vitrification came along that we could successfully freeze eggs, thaw eggs, and fertilized eggs. So now the statistics are 90% of frozen eggs will return to viability. 80% of those will fertilize. So that's a really good number. However, eggs are tricky, and there's probably a little less success with frozen eggs than there are fresh eggs. Some of that's clinic dependent. Some of it's probably individual dependent of whose eggs are whose. But on balance, if somebody had a choice with everything else equal of fresh or frozen, I counsel people to think fresh.
Okay.
Now, there are some big advantages of frozen eggs. They're in banks. So especially if somebody has a couple of issues, let's say someone is in our area of Washington, people are assigned diplomatically and militarily around the world. So if someone is off to some corner of the world and we have a month to take care of them and send them off pregnant, frozen eggs meets our goal very nicely. If we have a couple of particular ethnicity that we don't have a donor in our internal egg bank that would meet their needs, egg banks offer a lot of choice typically. So there are a lot of good reasons to use frozen eggs, but on balance, lean fresh over frozen if you have the choice.
Okay.
Great question.
Yeah, perfect. And I did want to, I have another question here. I know, Perla, you have a few questions as well. Back to the PGTA, is that...
Let that siren go by.
Okay.
We're very well protected here, fortunately, but there's a fire safety.
That's all that matters. You're safe.
Sorry. Back to PGTA, yes.
Yeah, back to the PGTA. Are these cells always removed from the embryo on day 5 of fertilization?
No, typically we remove them when that embryo becomes a blastocyst. So day 5 would be the earliest, day 6 would be next opportunity, and day 7 would be third opportunity.
Oh, okay.
That said, day 5 embryos are inherently better than day 7s, and day 6s are almost as good, meaning it's sort of like the rose on the rose bush that blooms early with the sun. You know, that's the lead one, and others may follow. Doesn't mean the others are bad, but we always prioritize day 5 embryos over others.
Okay, perfect.
Dr. Mottla, would you transfer a Mosaic embryo?
So that's another great question. That's a controversial question, Perla. Thank you for asking that one. I say tongue in cheek.
Tongue in cheek.
So Mosaic embryos are embryos that have been confirmed by PGT testing to have a mixture of chromosomes, meaning they don't come out as normal. Instead of saying 46XX is female, they may come out as 47 in some cells and 46 in others and so on. The challenge now is our practice is uncomfortable transferring mosaics. We don't feel we have enough data. People are doing it, and we've had babies born that are normal, but we've also had babies born that may have some problems. And I think we're too early in the process to make a general statement. Particularly because we don't know what chromosomes probably are the best ones to accept as mosaics. The point being, some of our chromosomes carry a little bit of information, and if you're off in that little bit of information, you're probably fine. Others carry a lot of genes, and if you make a mistake with that one, it's probably not a good thing. So it's something that we're gonna clarify in time as a society, probably within the next 3 to 5 years, especially if we're able to come up with a retest of that embryo and eliminate maybe a false test result on the mosaicism.
Thank you for sharing that. Here's another controversial question. You know, we have a lot of intended parents who feel that if they transfer 2 embryos, they have a higher success rate. What are your thoughts about that?
I think it depends on who they are. In other words, if you're caring for a 40-year-old set of intended parents, I think there's a good conversation and a reasonable approach to consider transferring 2 embryos. If you're caring for a 30-year-old couple, then or egg donation when the embryo is 28, 29, we've looked at our data carefully, and You may get a little increase in pregnancy rate, you may, but you pay for it in probably a 40% increase in twin rate. And twins are complicated. Often there's more miscarriage with twins overall, so a total loss. There's early delivery, problems with early delivery in terms of breathing problems, stays in the NICU and the complications that arrive there. For everybody who's had a set of twins, there's probably somebody else that you don't know about who's had some very serious complications. So we look very carefully at age and embryo quality and help couples make that decision, be it one or two, based on that.
This is a question that we get very often, so thank you for sharing your expertise on that.
Try again, your audio wasn't there.
So I was saying this is a question that we get quite often,
Sure.
so we appreciate you sharing your expertise.
Sure.
It's also a question as well that we receive quite a bit from same-sex couples who would really prefer to have twins, one of
Sure.
each of their genetics. Is that something that you are open to considering?
I think we're open to considering most anything with good counseling.
Sure.
Obviously, it depends on the surrogate too.
Yep.
You know, if that same-sex, say, male couple is using a friend or a sister as an egg donor and that person is 38, you know, I think that's a reasonable conversation. If she is 28, then we're uncomfortable with that because we don't want to place the surrogate at risk and we want to have a successful outcome for the couple.
Thank you. Thank you.
Dr. Mottla, now that we're in the middle of COVID, what are the protocol changes in at Shady Grove, and are you at this time advising the surrogates or anybody embarking in this journey to get the vaccine?
So we've come up with a protocol very early in the process. Unfortunately, that was not allowing partners in the office, so we've cut our exposure by 50%. We're doing all the COVID safe things that you would expect, but we're continuing care in the usual way. The sort of sad part about it is that at embryo transfer, which is the culmination of which we all work for, having the couple there together at the culmination of it was just plain, you know, professionally satisfying. So we can't do that now realistically and accept the additional exposure. So we do FaceTime, we give people a video clip of the transfer to take with them to the partner. We'll do anything to bring that partner in and make them feel a part of the process that they are the other 50%. In terms of COVID vaccine, our feeling and the guidance from our societies is that you probably should get it unless there is some medical reason that your health would preclude it. COVID's a bad thing. The vaccine is, the vehicle of the vaccine is established. What's new is the COVID piece of that vaccine. The data in pregnancy and that vaccine hasn't been studied, but COVID's a bad thing for sure. And although the vaccine is unknown in pregnancy, the data in pregnancy seems to be pretty favorable in terms of babies. We also worry that if someone was pregnant and got COVID, they'd probably be sicker than if they weren't pregnant, and that has some implication on their baby. So on balance, we're recommending people consider getting it, whether they're planning to get pregnant or are pregnant, unless there's a medical prohibition.
Okay.
That's really helpful.
You know, sticking with the COVID question, in terms of screening for surrogates as well as egg donors as well,
Sure.
Are you allowing the screening to be remote, the initial, and I'm referring to the initial medical screening for a surrogate, where pre-COVID they would come in and complete their screening process at your facility. Is that still the case, or are you allowing them to lessen the travel for that?
Yeah, we're individualizing it. We're using a virtual consult initially. We're reviewing records. The virtual consult works very well. It doesn't accomplish a mock embryo transfer or an HSG or a physical exam, but we're trying to work with people and be realistic and be flexible. If someone lives, within easy drive distance, I think a face-to-face still is value. If they have to hop a plane and take 2 connections between 3 airports, I think the risk is probably not warranted, and we'll figure it out.
Okay, perfect. Thank you.
And in those cases, what we've done is we brought the surrogate in a day early to have a face-to-face to make sure she's comfortable before anything happens. So we still have that safety net of a 1-day time.
Right.
So much, Dr. Mottla. I know that you are very busy, and we really appreciate the time that you've taken today to share your expertise with the intended parents looking to create their family with the help of a surrogate or an egg donor. And we look forward to continue working together.
That's mutual. Again, for everybody out there, I would encourage you to ask your doctor questions, be a savvy, assertive medical consumer. There's nothing we do that's hard to understand at all. You just need to have it explained to you and laid out nicely. So good luck to everybody. Happy New Year. Let's put 2020 behind us.
For sure.
Look forward to a new year.
Thank you
Thank
so
you
much.
so much.
All right. Take care.
Appreciate it. Have a great day.
Have a great day.
Bye-bye.
Bye-bye.